webpage after the meeting. For everyone's reference, today's agenda can be found under the first tab in the meeting materials. As a reminder for everyone, please remember to use the Healthcare Cost Transparency email inbox to send updates or questions. And a few quick updates on the committee membership as well as meeting process moving forward. So I want to note that our public meetings will be held via Teams moving forward rather than Zoom. And we've included a one-pager to go over details on how to participate in meetings using Teams, which you can find in tab 1 under tab 1 of the meeting packet with the agenda. And just a few things to note regarding the transition from Zoom to Teams. We will no longer have chat ability and no reactions. And then also the public will not need to accept to join as a panelist for public comment. You will just need to raise your hand. And on the back end, one of our team members will provide you access to be able to come on camera and unmute your microphone. And then other announcements, since the committee last met, which was in September, the cost board has appointed 2 new members who are joining us today. Dr. John Bramhall is the member representing Washington State Medical Association, and he is taking the place of interim member Jeb Shepard. And Katarina Lamarche is the member representing hospitals and hospital systems, taking over from former member Eric Lewis. We will hear more from them when we do roll call, and we will have all members introduce themselves, the agency and organization they're with, as well as what member position they hold on this committee. We've also lost member Emily Price. She was one of our stakeholder advisory committee members that represented consumers, and that's because she was recently appointed to the cost board. Now I'll turn it over to Chair of the Stakeholder Advisory Committee, Eileen Cody, to call the meeting to order.
Thank you. Welcome, committee members. It is now 2:05, and I call this meeting on February 19th of the Advisory Committee to order. We have the agenda in front of us, but we're first going to go through roll call and also review. The next step will be reviewing the minutes. We also have, besides September's meeting minutes, we have May's meeting minutes because we didn't have a quorum the last time to be able to approve. So I will now start with roll call. I'll call on members by your first name in the order listed on the agenda, and briefly provide your title and affiliation and what organization and the membership position that you hold on the committee. And as an icebreaker, if you could tell us one of your favorite places to visit in Washington. And I'll start with my name again, Eileen Cody. I'm the chair of the Stakeholder Advisory Committee, and somehow I don't know how that happened that I became chair, but I am a member of the Cost Transparency Board and serve as one of 2 members representing consumers on the cost board. My favorite place in Washington to visit is pretty much any winery in Eastern Washington, basically around Prosser. It's my favorite. So with that, we'll move on to Dr. John Bramhall.
Can you hear me through this microphone? Just
yes, we can hear you.
Great, awesome. Happy to be here. I'm taking over from, as we said before, Jeb Shepard. I think he's very sad to leave this committee. He was here representing the State Medical Association, and that's who I'm representing on the board at the moment. My favorite place to go to in Washington is, I like junk shops. So I'm going to say any junk shop, which gives me plenty of places to go in the state. Yeah.
All right, thank you. And then let's see, Patrick and Connor and Bob Crittenden are not making it today, I believe. So Paul Fishman. He here? No, Jamie? I'm going to mark the ones that we think that are coming, and I'll go back to that. Justin?
Hello, I'm here.
Okay, go ahead and introduce yourself.
Hi, everyone. I'm Justin Gill. I'm a nurse practitioner, and I'm the president of the Washington State Nurses Association.
And your favorite place in Washington?
My favorite place actually would be Seattle. I'm in Western Washington, so.
All righty. Jody? Oh, we're not doing well here. Louise? Louise?
Well, yes, I'm here. I'm
Oh.
Louise Kaplan. I'm also a nurse practitioner, and I am representing ARNPs United of Washington State. And my favorite place to visit is Mount Rainier.
All righty. And Katerina?
Hi, Katerina LaMarche. I'm representing the Washington State Hospital Association, and my favorite place is probably the Washington Coast.
All right. And Vicky? Vicky here? No, okay. Natalia? No. Sulan?
Sulan will not be able to make it today.
Oh, he's not gonna, okay. Michelle?
Yes, I'm here. I'm Michelle Ritala. I am with King County. I'm the benefit strategist for their employee benefits program. And I'm here representing the employer purchaser perspective.
Okay. Paul Schultz?
Wait, I do have
Oh,
a
I
favorite
forgot,
place.
yes, we're your favorite.
Yeah, I
place.
have lots of favorite places, but I just recently I'm getting into bird watching, and I went to Billy Frank Jr. National Wildlife Refuge, pretty close to Olympia there.
Right,
And that is an awesome place to look at birds.
and Nisqually, yes. Okay, Paul Schultz?
Good afternoon, everyone. I'm Paul Schultz. I'm Executive Director of Actuarial Services for Kaiser Permanente, Washington. So here representing payer side perspective. For me, it's hard to beat Olympic National Park. It's the variety and the nature without peer.
Okay, and then Dorothy? Dorothy's not here? Oh, I see DT. She must have stepped away. Wes? All right, well, we'll hopefully some of these people will be joining us and we can have them introduce themselves when they get on or at another point. So now please join me in turning to the minutes of May and June, not May, I'll get it said, May and September meetings.
And Eileen, I'm very sorry to interrupt you. Unfortunately, we do not have a quorum presently. We are one
okay.
member short of a quorum regarding the meeting minutes.
Did any of the other people anybody that didn't get to introduce themselves, are you here now? No, okay.
I do
Well,
see
then I
that
guess
Dorothy's here, but I don't know. I'm trying to see if she has the ability to come on camera and unmute.
I thought I could see the DT, so I thought she was here.
Yeah, I do see it too. So I counted Dorothy, and I think with Dorothy present, she might be having tech issues maybe, but that does bring us to a quorum.
Well, we'll wait until we hear from her because I don't really feel like we can't have a vote without her being able to speak to us. So
Right.
We'll just move ahead and come back to this. If that works, I think we can make it work. So at this
Yes.
point, then I'm going to turn it over to Harrison for public comment.
Hey, Eileen.
Okay.
Oh,
Eileen,
there?
this is
Oh,
Dorothy. Can you
is that
hear me?
Dorothy?
Oh, right. Yay, Dorothy.
Yeah, I had to go out and come back in, and now I'm being allowed to be seen and heard from.
Okay.
So I am here now. Sorry.
Oh, all righty. Do you want to say who you're representing and your favorite place in Washington?
Okay. Dorothy Teeter. I'm a consumer rep on the board, and I'm going to be very parochial and say it's Shill Shoal Bay, which we like to go to and look at the sunset almost every night. But am I echoing?
No, you're okay.
Oh, I'm just echoing to myself. Okay.
Okay, well then with that, we have, do have a quorum?
Yes.
Mhm.
Okay.
Yes.
All right, so now we can turn to the minutes. Does anyone, oh, and as a reminder, there's a recording of our past meetings are posted on the web page. At that point, is any discussion of the meeting minutes or do you have any proposed changes to the minutes? No, don't see anybody. Can I get a motion then to approve the minutes?
I make a motion to approve the minutes.
Thank you. And will someone second that motion?
Second.
Thank you. Any opposed? All in favor, say aye. Yes, or raise your hand.
Aye.
Aye.
Okay. Any opposed? Okay, with that, we have approved the minutes. The meeting of the minutes has stand approved. Now I can turn it over to Harrison for public comment.
That goes back to me. Thanks, Eileen. Okay, for public comment, if a member of the public wishes to provide public comment at this time, please raise your hand. When you are called upon, please state your name and affiliation, if any, before speaking. Please do not raise your hand more than once. This helps to ensure that everyone has a chance to speak. You are also welcome to provide comments in writing via email at any time. Please remember that this is the time for public comments. Any questions and answer sessions during the meeting are times for the committee members to ask questions only. Okay, let me see if there's any hands.
Not seeing any hands.
Me either. We'll just give it a second. It's Teams. Maybe I'm missing something. It's new instead of Zoom. Okay. Yep, I don't see anything, so I will turn it back over to you, Eileen.
Okay. Well, then we will move on to tab 4. And I'll hand it back to Ross Valor, the Director of Boards and Commission, who will provide us an abbreviated version of the presentation that the cost board heard at their last meeting. Ross?
Yes, thank you so much, Eileen. And Jen, if you could proceed to the next slide. Thank you. We were hoping to just provide a quick overview of the discussion at the January 28th cost board meeting, first meeting of 2026. And this year we, I believe we'll cover it in a few slides here, but have a work plan that has us covering 3 primary topics, the first being market oversight. And so that's what we'll be going through today, that overview. But first, we're going to get started just with a quick recap of the public hearing and the data call. Up on the screen, you'll see one of the slides from our data call presentation. This is giving an overview of cost growth in 2023. Again, this is our 2025 data call. We're a couple years behind in terms of the data, so just wanted to make that clear. The state has a 3.2% cost growth benchmark. That is a goal to hopefully slow the rate of cost growth for healthcare in Washington. In 2023, we were at approximately 7.2, 7.3%. So, roughly double what our goal was. So, still seeing growth in the same service categories as prior years that are driving costs the most. And those 3 were prescription drugs, professional specialty, as well as hospital outpatient, were the primary cost drivers across commercial Medicare markets as well. And we can go to the next slide. And so this is showing a slightly different measure. This is total medical expenses. The prior slide was total healthcare expenditures for Washington State. Again, this is medical expenses, so costs incurred to render services. Again, you'll see the breakdown on the two charts to the right of the different service categories and how they accounted for the proportion of spending. Prescription drugs, hospital outpatient, professional specialty, again, are those that are growing the fastest. And you can see in the chart in the center of the graphic, the rate of growth of each of those service categories since we started measuring in 2019 until 2023. We have two other primary topics that we'll be covering at the cost board this year. One of them is prescription pharmacy spending, because we've seen that come up in numerous data calls as a top cost driver. And our other topic is going to be primary care utilization, as we know that's a way to combat rising healthcare costs. And if you could move on to the next slide, please, Jen. Thank you. In terms of next steps related to the data call and follow-up, we intend to present one of two presentations on what we've referred to in the past as cost drivers. We'll have our first at our March 25th cost board meeting and plan to have a follow-up in a little bit more detail at the May cost board meeting. We recently published the benchmark brief, which has the more information similar to what you saw on the previous slide, breaking down the data call growth in different markets and service categories. That is on our website. And if you have any difficulty accessing that, please send us an email and we'd be happy to direct you to that. And like I noted, at our next meeting on March 25th, we'll go through our first cost driver analysis, followed by a second one in May. And Jen, if you would move to the next slide, please. And then before transitioning into a full wrap up of the January 28th meeting, just wanted to cover some of the themes that we heard at our public hearing that we held in November of last year. The public hearing's main topic was healthcare affordability, and we heard from three different panels of constituents in Washington who provided really helpful perspectives on healthcare affordability from their perspective. We had consumer, we had business, labor, provider, and so payer. And so some really helpful perspectives, and wanted to bring some of the key themes that we were able to find in those themes that we heard at the public hearing. So first, here is consumer. We heard from multiple panelists about the unaffordability of healthcare from a patient or consumer perspective, and we know that those costs are rising, so wanting to be mindful of that. Noted again that the healthcare cost growth benchmark has not been met, and there was notable concern related to the federal changes, HR 1, related to Medicaid, that folks were concerned about in impacting access and ability to afford care. And then the last bullet, by 2030, the price of cancer care is expected to double, and we heard multiple comments related to specific specialty areas and the costs related to getting care in that area. So just wanted to highlight those for folks for awareness. We also have the recording available of the public hearing on our website if you'd like to hear some more about this. If you go to the next slide, Jen. The next we want to highlight is themes that we heard from industry at the public hearing. The first one I think is really important to note. Multiple year cost growth trends and patient acuity should factor into benchmark performance. I think we heard a lot of helpful feedback from industry about ways that our cost growth target, is helpful and is not helpful, in other criteria that it should perhaps consider. We had noted at the public hearing that the cost board team is going to do a refresh on our benchmark, which we plan to do over the course of 2026. So we will continue to update you on that, but just wanted to note that, we're hearing these comments. Another note too that was helpful is pointing to higher utilization of services as one of the drivers of increased costs. That's something that wouldn't come out necessarily in our data call, so I think that's important to note. And then obviously the impacts related to inflation and impacts on the supply chain. We heard about that. We're making it difficult for industry as well to be able to provide quality care with current reimbursement rates. So if you would go to the next slide, Jen. And we combined a few themes as they crossed over to one another, but consumer and labor. This primarily focused on impacts to families and those that are currently in the underinsured bucket who may likely forego coverage or not be able to afford it in the coming year. In wanting the cost board to consider those folks in any efforts that can be done to ensure that they can maintain and or afford coverage. Also heard quite a bit about healthcare wages, both from industry and from labor, that healthcare wages are rising quickly, as well as difficulty being able to afford some of those positions, as well as finding qualified candidates to come and work in various locations throughout Washington have all become challenges. And then a handful of recommendations here I'll leave for you to read, but thought those were all really helpful to us. And if you could go to the next slide, Jen. And this is our final themes from our business panel. We heard that premiums, costs for private healthcare is becoming unaffordable for employers. This is something we've been hearing quite a bit over the past year and looking for different forms of relief from the increased premium. And it also has an impact on employing or maintaining employees. When healthcare is not provided to employees, they're more likely to leave the position. And so being able to afford quality healthcare is an important retention strategy for employers. So seeing this as not just a healthcare issue, but also kind of a business need. And then needing more transparency in terms of mergers, acquisitions, consolidations, pharmacy costs, charity care, kind of some of the structural components of our healthcare delivery system and better understanding that to allow them to better prepare for changes or react, when there's an unexpected event like COVID. So I thought that was really well stated and just wanted to call that out for you all. And so that covers roughly our public hearing and the themes that we heard from the panels. Again, if you have any questions or would like to hear more about this, we have the recording available on our website. If you would go to the next slide, Jen. Oh, I apologize. Oh, yes, perfect. Well, I guess I missed one panel. Apologies. Just wanted to cover this real quickly. Our payer and industry panel themes, needing to invest more in primary care. Again, that is one of the topics that we're going to be focusing on at the cost board level this year. Mergers and acquisitions, that speaks to the market oversight topic we'll be discussing today. And again, impacts related to charity care and HR 1. And a call for the cost board to focus more on the bigger picture of affordability. And so I think we'll be hearing a little bit more about that today. So again, a recording is available on our website. If you have any questions or any other follow-up, happy to hear about that. And now we'll move into a quick overview of kind of the work plan for the cost board in 2026. And Jen, if you would go to the next slide, please. So as I mentioned, we have a work plan for the year that broadly has us covering three primary topics. The first being the issue of the increasingly consolidated healthcare market here in Washington. And so we broadly been calling this market oversight. The two primary areas that we're hoping to learn more about and, if appropriate, get recommendations from the cost board on is transaction review. When there's a healthcare facility or two that are considering merger, consolidation, affiliation, the ability of the state to get some advance notice. And currently we don't have approval or denial authority, but whether something like that would be appropriate and beneficial for Washington. The other aspect that we're talking about in market oversight is the transparency element, both ownership transparency, which might look something like a provider registry, which we'll hear a little bit about today, but more or less that would be compendium of healthcare providers and facilities throughout the state that would give awareness to consumers as well as regulators, business, industry of who's operating and providing healthcare services in Washington. Another example might be something like price transparency. There's efforts on the federal level and in state law that require hospitals to publish prices, and there is some updated rulemaking going on right now at the federal level on that. So those are a couple examples of the types of market oversight activities we're covering. The next topic is slowing spending growth, and we're intending to focus primarily on pharmacy spending for that. Again, that's driven by seeing pharmacy spending being a top cost driver since we began doing our data calls back in 2019 and wanting to focus in on that, provide cost board members with more information, and see if there's any policy recommendations the cost board would like to provide the legislature in our annual report. We also plan to collaborate with our PDAB unit. I apologize, I'm going to forget what the acronym means, but it is a board that is designed to look at a select list of pharmaceuticals with the intent of hopefully lowering the prices on those. And then finally, primary care, specialty care imbalance, and wanting to focus on increasing primary care utilization throughout the state, and really looking at it as a multifaceted issue. We do have a primary care advisory committee where these issues have been discussed for the past few years, but wanting to really devote some more time and resources to that this year. The state has a 12% primary care spending goal, meaning that the state has identified that they'd like 12% of all healthcare spending to be directed to primary care. Last year, again, for 2023 data, showed that we were at approximately at about 3.5%. So not quite up to the 12% level we're hoping to get to, but hopefully through some of the work that we do this year, we can begin laying the foundation for reaching that milestone. Just highlighting a few of the things that we hope to address. We hope to collaborate with the Workforce Council. As we know, or we've heard that primary care providers, nurses, folks working in that field are increasingly becoming difficult to find. And so wanting to make sure that we're taking kind of a holistic approach at looking at this. And then also wanting to give some updates too on our primary care data collection processes. I believe we've engaged in a few process improvements on that over the last year. And Jen, if you would move to the next slide. This is just a quick demonstration of what we're hoping to do this year with each of these three primary topics and how we plan to hopefully engage and collaborate with the advisory committees and the cost board. It had been a goal of ours last year to separate what had previously been the joint data issues and stakeholder advisory committee meetings. And so we were able to do that this year, and just wanted to give you an overview of how we were intending to kind of utilize advisory committees related to these topics. So using market oversight as an example, we held our first meeting in January, went over high level what we mean by market oversight, what's the current lay of the land in Washington, and what information the cost board would like to hear from the Stakeholder Advisory Committee on this topic. We went over those questions with the cost board in January. Those are the questions that we'll be discussing today in our panel. And we also had some discussion with the cost board about the best way to utilize advisory committees. And it was, the understanding was very much that we need to take in and relay the feedback that the Stakeholder Advisory Committee, the Data Issues Advisory Committee are providing on these topics. So really creating a forum for folks to share their thoughts, concerns, pros, cons about the strategies being talked about at the cost board, so that we can relay that information to cost board members so that they can contemplate that when considering recommendations that would ultimately be included in the year-end annual report. So we are here today at the Stakeholder Advisory Committee meeting. Again, we'll cover those questions that the cost board identified on market conduct or market oversight and bring those back to the cost board at the March meeting. Hopefully that refines their thinking on the topic. And then we plan in March to bring in some speakers from other states to discuss their market oversight programs, to give some context and some understanding of how other states are operating in this area. This currently has Data Issues as meeting in April. I think we're going to pivot and have our Primary Care Advisory Committee in April, but we'll communicate with folks via Gov Delivery and email on that topic. But you can imagine the questions and issues that we address at the March cost board meeting. We then work with our cost board members to identify helpful feedback that could be derived either from Data Issues or Primary Care, whichever advisory committee meets in April. And then again, we would bring that back to the cost board in May. And then again, because we're kind of envisioning each of these topics as 3 meeting arcs, hopefully in May we'd begin to identify preliminary recommendations and then revisit them throughout the year, but kind of set that foundation for where we're hoping to go with market oversight. And again, we would expect a similar trajectory for each of those 3 topics that we'd identified. And if you could go to the next slide, Jen. That is the end of the very quick overview of the public hearing, as well as our January 28th cost board meeting. Hopefully that provided some insight into what we're hoping to accomplish this year and how we're hoping to utilize advisory committees. We reflected quite a bit on, we held a reflections meeting with both Data Issues and Stakeholder last year and got a ton of good feedback, and apologize that it took us the majority of the year to get to this point. But we're hoping that this meeting, as well as future meetings, align with folks' expectations. And if there are improvements or concerns, please let us know, as we're hoping to really get the most out of this group and feel very lucky to have your time and want to make sure we're using it well. So, and with that, I believe we are transitioning to our next presentation, which is going to be
OFM
by...
yeah.
Yes, which, correct me if I'm wrong, I believe we're throwing it to Mandy Starr from OFM to give us a quick update on the Washington State Health Plan and Resource Strategy.
Hi, can everyone hear me?
Yes.
Yes.
Okay, great. Yeah, so I'm here to just give an update of where we are on the state health plan. I think I've presented before just how we were working on the approach. So this is an update to where we are now. I think we're probably going to be updating several times throughout the year just as we progress along with this. Next slide. So just a brief background in case nobody was here for the previous presentation. This is referring to RCW 43.370. OFM did release a state health plan back in 2010, but found some major gaps in data and wasn't able to actually fulfill all the requirements in that RCW. So we spent the past 15 years trying to fill in some of those gaps. And then the recent substitute Senate Bill 5568 updated the RCW and gave us some new deadlines. Next slide. So this is just a brief what that Senate bill updated. We've got some new deadlines. We've got an approach deadline that is June 30th of this year, and then the final plan is due on December 31st of 2027. And then we will have an update cycle about every 4 years after that. Next slide. So current progress. So in the RCW, there's 5 objectives that are called out. So we've been working on meeting with tons of stakeholders, having input from our technical advisory committee, and working on drafting the approach to those 5 objectives. We are preparing for our public hearing, and at the end of this presentation, I'll give you the dates and the times of that public hearing. We've been meeting again with stakeholders, reviewing a lot of state agency reports and strategies and documents that state agencies have produced over the past couple of years. And then we also are finalizing our IRB applications for some of the data that we'll be requesting too. Next slide. So this is the language from the RCW that talks about objective 1. So the first objective is more of the population demographics for the state. Next slide. So these, I'm not going to read through all of them. These are the goals that we've set forward for objective 1 based off of the language that's in the RCW and also some of the meetings with our stakeholders and with our technical advisory committee as well. So the main thing is establishing who lives in Washington, showing that statewide, linking demographics and economic conditions to some of the healthcare system, really understanding where people live, what drives them to healthcare, where are some of the pressures on healthcare, and looking at this from a geographic standpoint instead of across the state, looking at this regionally as well. Next slide. So there's about 6 categories of information that we'll be presenting for the for objective number 1. They're split up here: demographics and population trends, looking at some of these economic indicators, health status and outcomes, looking at healthcare coverage and access to care, looking at measurements around quality of care, and then costs as well. We're developing key questions that'll go along with the goals, and then we'll also be presenting the data sources as well in the approach. Next slide. So objective 2, this one is looking at more of the healthcare facilities and services that are available. So this is a big data inventory that we'll be doing for across the state, looking at projections of need. So we'll be outlining how we'll approach how to calculate need. And then several of these sub-pieces deal with certificate of need program. So policies around guides to add new or expand healthcare facilities, and then assessing the availability of healthcare providers and the healthcare workforce. Next slide. So we have agreed and talked with our technical advisory committee to look at capacity by accountable communities of health. We can't necessarily do this at the county level because in some counties we've got very small numbers. And so we've determined that we'll do this by ACH, but we'll overlay other types of maps too. So some of the Medicaid health service areas, also tribal lands as well. Excuse me. We'll be providing some guidance on decisions and how they should be made when growth occurs. This is specifically growth around the population and population needs. And then we also are trying to understand with this objective regional support for facilities and services too. Next slide. So the way we're going to approach objective 2 is we're going to probably split this into 4 table templates. Listed here are the 4 kind of topics that those table templates are going to assess. We're going to try to apply measures and methods that are already in use. So we're not going to be coming up with our own, but what state agencies and other stakeholders already use to measure some of this. And then we also want to try to avoid measures that don't have a regional context. This is one of the problems. If we report things at the state level, it doesn't necessarily reflect what's happening in different regions across the state around healthcare. Next slide. So objectives 3 through 5, I just have summarized here. My staff and I haven't gone through them in detail yet to lay out the approach. This is what we plan on doing in the next week and 2. But a lot of them are going to be building off of objective 1, looking at the population demographics and where healthcare is, where the need is in the state. Objective 3 is our inventory of existing data resources. So part of objective 1 and objective 2 are going to contain a little bit of a wish list too, of in order to determine projection of need for certain services and areas, and also growth drivers. There's probably some additional data pieces that we need that we may not have. And so those 2 objectives will help us build that inventory of not only needed data resources, but identifying where the data gaps are. And that's what objective 3 is really focusing on. Objective 4 is looking at emerging trends in healthcare. And we got a lot of input from our technical advisory committee on what they would like us to focus on around emerging trends. And then objective 5 is around rural healthcare needs and a rural healthcare strategy, which we'll be pulling heavily from the Rural Health Transformation Grant applications, and then it also taking out some of the subsections from the previous objectives as well. Next slide. We are going to have to address some other issues in this update to the state health plan as well. I mean, one of the biggest ones is the impact from HR 1. Not all of the impacts are going to be in the data that we're going to be using. And a lot of the impacts we still aren't entirely clear on. Some of the guidance for HR 1 impacts we won't know until this summer. So after our approach is already submitted, this will affect Medicaid eligibility. It'll affect H-1B visas. There's a lot of moving parts of HR 1 that we're going to at least discuss in the state health plan, but we're not going to have the data to be able to really look at how those are being impacted in healthcare. We'll also talk about any recent changes in laws from this past session that may affect some of the healthcare pieces in the future. And then also, if anything comes out of this session that affects reporting requirements, that will feed into some of the data inventory pieces. So we'll also have a section of the report that will discuss this too. And then next slide. So hit the next step. So we're finishing outlines for the objectives. That information is all going to go onto our OFM website. We're building out pages specific to the state health plan and specific for each of these objectives. This is all to prepare for a hearing for March 24th from 10 to 11 a.m. This will be a hybrid hearing, both in person and online. It's a little strange. We actually have 2 hearings that are associated with this plan. So the first hearing is on the preliminary piece, which will be our approach. And then we'll have a second hearing later on after we've already run the results and shown some of our outcomes. So 2 different public hearings. We'll be gathering input and feedback. The time for input and feedback will be not only during the hearing, but we'll also leave it open as well. And we're also taking feedback and input at any point in time. We will have to have a certain time that we kind of cut things off so that we have time to prepare the report, because it's a report to the legislature. We'll have to have it finished in early May in order to go through all the review processes and be ready to turn into the legislature by June 30th of this year. Next slide. And so if you have any questions or anything, please email me. We're always interested in hearing things. We've met with around 50 different stakeholders so far. We will be meeting, I know, with a lot more people in the next couple of weeks. We're trying to get the documents posted up on our website first, and then we'll be starting up a lot more meetings and gathering more information from people. And if there's topics or issues that you feel like should be in the state health plan that you don't feel that maybe any of these objectives I've talked about would cover it, please talk to us, let us know, and we can tell you whether or not that's going to be in scope this time around.
Thank you
So
so much,
all I have.
Mandy. I know in the past you'd mentioned perhaps seeking out individuals to participate in any groups. Is that a need at all at this point, or not?
So probably once we get some of the documents posted and have the hearing, I think we'll probably do that. I mean, at this point, we're trying to at least show the approach that we'll be using, but we definitely have a list of more groups to follow up with. Everyone who we meet with usually gives us additional people to talk to as well. As we get more into the data itself, I think we'll be talking to a lot more people. I mean, if you haven't been reached out to yet, you're on our list.
Thank you, Mandy. And just want to see if any stakeholder committee members had any questions or comments they'd like to provide to Mandy or ask any questions.
I will say the one thing we probably will be reaching out to people about is a little bit of historical context. There's been some pieces that we've talked to people about that we don't know if the state has done in the past or not. And so that we will be kind of talking to some people around, well, has the state actually looked at risk assessments around healthcare by region, or if we've looked at specific, what have been some of the activities that the state has done around healthcare in the past that for some reason either we don't do anymore or just kind of fell off the radar, but would still be helpful if we started that back up again.
Okay, excellent. And I'm not seeing any hands, so just wanted to thank you again, Mandy. I know this is a huge project. I think you mentioned the state health plan hadn't been updated since 87 or 89, so I can imagine 30 years worth of updates is no small task. So just want to say thank you for all your work, and please let us know how we can help.
Great, thank you.
Yep, take care, Mandy. And I believe our next section is also a quick presentation on healthcare market transparency and oversight. This is an abbreviated presentation of what was done at the cost board last month. The intent of this is really to give you some background on the market oversight topic, but more so to inform you of kind of what the cost board learned about at their last meeting. Hopefully this aids in our following panel discussion, going over some questions. So apologies that this is short and quick, but if there are any questions or additional piece of information that you'd like to have, please let us know and we can try and track that down for you. And Jen, if you go to the next slide. So just kind of lay of the land here, consolidation in healthcare. A growing trend is the consolidation nationally and in Washington State of healthcare markets. And we wanted to start by just trying to wrap our heads around some of the verbiage that's used in this context. We hear about mergers, integration, acquisitions, and tried to do our best here to kind of just define those terms. Just to go through them really quickly, horizontal mergers that occurs between entities that offer the same or similar services, and we provide a few examples of that. Vertical integration, which I think we're all somewhat familiar with, entities that offer different services along the same supply chain that integrate. Cross-market mergers is something that's seemingly happening more frequently in recent years, where two providers that operate in different geographic markets merge. So perhaps two states, or it could even be regions within the country where large provider organizations or health systems merge. And then corporate acquisition. This is referring specifically to scenarios where an entity is not engaged in the business of healthcare that would acquire then a healthcare entity to cover that. So if we could go to the next slide. So the next main question is, why is consolidation occurring? We certainly don't have a simple answer to that, nor do I think we're in a position to give an answer at this point. But a few of the reasons that we saw in the academic literature in talking with some of our colleagues in the academic field, at Brown in particular, have identified the following as some of the drivers of consolidation. One is financial stability. The market is becoming increasingly difficult to to play in if you don't have market power. And so seeing that market power provides better bargaining leverage, in that it makes it easier to recruit and retain, and seeing kind of a trickle-on effect related to health systems growing and having more market power in a given region. And obviously Medicare and Medicaid payment differentials and incentives that occur depending on what populations are being served by a particular entity when they are consolidating or seeking to consolidate. Operational efficiencies and improved outcomes in the sense of higher reimbursement levels or more predictable financial streams for entities. This isn't referring to quality outcomes. And I imagine there are many, many more reasons, and I hope to hear more from the panelists today. But this is kind of the high-level ones that we were able to pull out of research and discussions with our colleagues. Jen, if you could go to the next slide. Results of consolidation. Consolidated entities amass market power, leading to a host of issues that we've listed here. Not all bad, but different issues than I think we'd been used to seeing back in the 90s and early 2000s. Some of those are limited competition, higher patient prices, increased spending on healthcare, less access, fewer choices for patients, decreased or unchanged quality of care, slower wage growth, and mixed impact on access, including rural areas. And something that we've been trying to be careful to note as we open up this market oversight discussion is trying to avoid demonizing consolidation or mergers, acquisitions, understanding those are necessary pieces of kind of maintaining these very complicated health systems and provider organizations, but more so looking to see what, if any, improvements can be made in terms of how we regulate these, how we engage with them to hopefully lower costs, but likewise maintain high quality and access for Washington patients. So kind of trying to thread the needle a little bit there, but wanted to at least mention that we don't think everything related to consolidation is bad, and that there is some necessity to this. So just want to make sure we're being consistent with that messaging. If we go to the next slide. So we were, well, more specifically, I was fortunate to be able to attend a presentation put on by Milbank Peterson, who is a philanthropic organization that has provided support to the Cost Board in the past. And we were able to listen to several presentations by Aaron Pusey-Brown, a professor at Brown University in their Center for Affordability. And we discussed, like I said, market oversight and got some really good information. So that's where this slide is coming from. What I want to note and what I found surprising kind of coming into this topic, the literature does not point to any improvements in quality in healthcare consolidation. It doesn't necessarily reflect that quality is going down, more so that there's no impact or limited impact. So in terms of thinking about impacts of consolidation, that I found that to be interesting, that I think you would assume that quality would improve if you're consolidating, but the data is not showing us that at this point. And there's a variety of different data points here for folks to take a look at. And if we could go to the next slide. And then costs was the other primary area that we were looking at as it relates to consolidation and acquisitions of healthcare entities. The academic literature is pretty consistent on this point that consolidation does increase prices and spending for healthcare entities who are consolidated. We go through here some of the different types of consolidation, whether it be horizontal, vertical, cross-market, and essentially across the board, there seems to be price increases associated with this. So that is certainly an aspect that we're really interested in trying to better understand and potentially provide some recommendations in how we could better address the rising costs related to consolidation for Washington patients. And Jen, if you could go to the next slide. So this is the, and I'm going to butcher this, I apologize, Herfindahl-Hirsch index. On the next slide, we have it typed out for you. So apologies for butchering that. But essentially, it's a proxy measurement of market power that's been developed to kind of give us a understanding of how consolidated a particular market is. This is a snapshot. I believe the citations are on the following slide. Of 2022 national and how consolidated a given state's hospital market is. Anything over, I believe it's 2,500 is considered highly consolidated. So if you just take a quick look at this map, you can see that the majority of the country is highly consolidated. Washington is on the higher end. You can see we're turning orange with red being the highest level. So relatively high consolidated market here in Washington. If you go to the next slide, Jen. Thank you. And this one's a little bit more specific to Washington. Washington has a moderately to highly concentrated health insurance market. We broke it down here by large group, small group, individual market, and you can see the respective HHIs for those, with individual being moderate. And some of the reasons that we're seeing this increase in HHI here, insurers purchasing physician practice, PBMs, healthcare benefit managers, data analytics, and this increasing affiliation consolidation pattern. 54% of hospitals are affiliated with a multi-hospital system, and this is Washington, 8 multi-hospital systems that take up 90% of licensed beds, 65% of staff beds, and employ 65% of MDs and PAs who work in Washington hospitals. Private equity ownership has also grown over the past decade. So far, at least, we have not spent a ton of time focusing on private equity this year. We did have bringing in academic from Brown last year at the cost board in October to discuss private equity, but want to start more high level with market oversight as a topic and see if you or our cost board members have more specific interests in addressing private equity, but at this point kind of taking it a level higher and not focusing just on one particular actor in this healthcare consolidation acquisition realm. So, but certainly private equity plays a role in this. If we could go to the next slide. What is market oversight? I think there's a lot of different names that this topic can go by, and so we just thought it would be important at this point to just clarify what we meant by it. Typically, market oversight is a term used in the insurance world. Our Office of the Insurance Commissioner, for example, has a market oversight unit that provides oversight of carriers. That both covers a financial and quality aspect. What we mean here when we're talking about the cost board is referring to the state tools used to monitor, review, and respond to the healthcare market activity. We included a couple examples of what that might look like. But again, when we're referring to it here at the cost board, we're talking about state tools to monitor, review, and respond to healthcare market activity. I think the easiest example of that is some type of transaction review when there is a potential healthcare related transaction that the state be notified and conduct some type of examination on that would be an example of a market oversight tool. Focusing on structure and behavior of healthcare markets, not just prices. This is, again, a slightly bigger picture way of addressing affordability, access, equity from more of a delivery system level. States use market oversight to better understand how consolidation and ownership changes affect healthcare costs over time. I don't have the exact number of states. That's something that we can get who currently have healthcare market oversight programs. I'm aware of Massachusetts, Oregon, and California. I believe there are others, but those are the ones that we've been in close contact with and plan to feature them at, or at least Oregon and California at our March meeting. So there are other states who have invested in this and seen some results related to their market oversight activities. If we could go to the next slide, please. Also wanted to be careful to carve out at the onset what we're not talking about, at least as it relates to our conversation here. We're not talking about price setting or some endeavor to eliminate M&A action here in Washington. Also mindful that the way that we're defining market oversight as state tools to kind of look at the activity of healthcare market participants does cross over with antitrust in some ways, as you could certainly see in scenarios where there's a merger, affiliation, consolidation occurring. There may be antitrust concerns as well. That is not our domain, so that is not an area that we'll be focusing on here. And what it is, early warning, transparency, strategic intervention. Again, as we've been talking about it, we've been thinking of it as more of a collaborative process of working with healthcare entities to have that early detection, warning, and as well as for consumers and patients in Washington as well, that they would be aware of a proposed transaction in advance so they could prepare accordingly. If we go to the next slide. I'll just cover this really quickly. This is a variety of different policy ways to address these different issues within the market oversight context. So, for example, transparency of ownership and control. Some of the policy concerns that get identified with this particular issue is, a lack of accountability, a lack of detail about who owns or controls particular healthcare entities, healthcare transaction oversight. Again, another policy approach to address market oversight concerns. And again, this oversight authority is typically created to address the policy concerns identified, consolidations, costs, closures. So we thought this slide was helpful in kind of providing a few different examples of policy solutions or approaches to address a variety of different concerns that arise related to market oversight type activities that healthcare participants may be engaging in. And if we could go to the next slide. Just wanted to also do a quick overview as we understand it. And I want to note at the top of this slide, this was done internally, although we did check it with some other agencies and colleagues, but happy to be corrected if there's something that we failed to include kind of in the current lay of the land, as I know that many of the participants in today's meeting are engaging with this on a much more on a personal level. So if there is more understanding that we didn't capture here, please let us know and be happy to update it. But in terms of kind of the current lay of the land, we have one federal law that we mentioned here, Hart-Scott-Rodando. Again, that's focused primarily on antitrust, does have some crossover in terms of notice requirements for healthcare entities. Not anything that we're involved in terms of as a state, but I think it's good to note that is frequently if a transaction is required to provide notice under state law, you're probably going to be required to provide it under Hart-Scott as well. So just wanting to flag that. There is an incredibly high threshold for each party on Hart-Scott-Rodando. I think I believe it says 25.3 million. I think it's 125.3 million. Apologies if that one got cut off there, but these are very large transactions that the federal government's looking at under Hart-Scott-Rodando. Moving to Washington law, we have the Consumer Protection Act. Again, this isn't designed specifically for healthcare entities. This is more looking for actions that sometimes occur during the course or before or after transaction related to consumer protection laws. Is everything clear? Was notice provided? Was there any type of deception or misleading practices involved? So not specific to healthcare, but you could see how some of the concerns identified in the previous slides could be addressed through a Consumer Protection Act. Our most specific law that we have that deals with healthcare entities and mergers and acquisitions is our healthcare material change notice requirements. This is administered by the Washington State Office of the Attorney General. You can see the facility types it applies to. One very important note about the material change notice is that's all it is notice. There is no review or approval, disapproval authority currently. So this is simply providing the Attorney General's office notice of a proposed transaction. And they have a certain amount of time to request additional documentation and can, kind of slow the transaction, but I'm not aware of any ability to actually disapprove that. So it again is more of in a notice function currently, and also has somewhat limited scope in that it only applies to hospitals, hospital systems, or provider organizations representing 7 or more providers in contracting with carriers or TPAs. So do have this law in the books, somewhat narrow scope, and again is just providing notice. Our Certificate of Need program does review hospital merger, sale, or lease of an existing hospital. That is a very narrow review. And again, that's within the context of Certificate of Need and the new subsuming entity obtaining the Certificate of Need post merger, sale, or lease. So does kind of review the transaction, but under a different set of Certificate of Need criteria. And then nonprofit hospital acquisition does have a review process associated with it. I don't believe the state has had a nonprofit hospital acquisition in the past 5 years, so not something we see particularly frequently. And if we could go to the next slide. Just moving through this quickly, again, was just trying to orient COST board members to why this topic was coming up. And we've had in the past 2 years a number of requests from COST board members to look at different aspects of this market oversight question. And so you can see some of those that were mentioned in past years. So this is just our attempt to, demonstrate how this topic is kind of aligning with past requests by the COST board. And if we go to the last slide. Again, next steps, we plan to bring all of the information that you provide today to the COST board at the March 25th meeting. It'll also be included in meeting minutes, and we are going to have a recording of this meeting available as well. The intent really is to bring as much of the feedback and expertise that this body has back to the COST board to inform their thinking and decision making related to market oversight. So we've developed a list of questions for today that we're going to go over with our panelists who are stakeholder committee members. And then we plan to open it up for any stakeholder committee members who'd like to provide responses to those questions. And again, don't want folks to feel necessarily limited by the questions. Is the goal here for us today is to get as much feedback as we can on this market oversight topic. So without further ado, we can transition into our panel discussion, and I will hand it back to Eileen to facilitate that panel.
All right, thanks, Ross. That was a good update and summary of what we discussed at the COST board. So as Ross said, we're going to move into the last portion of today's meeting, and we have drafted, I'll phrase it that way, some of our members to be panelists, and we tried to cover the different areas that you represent and to get different perspectives. Dorothy Teeter is here as a consumer advocate, and she'll speak on how consolidation market changes can affect patients' access to care and affordability. Katrina LaMarche is from the Hospital Association and will offer system-level perspective on transactions, operations, and community impacts. Justin Gills from the Nurses Association, and he will share insights on how consolidation and market oversight affect the healthcare workforce and patient care. And Michelle Ritala is a representative of employer purchasers, and she'll discuss how market dynamics influence costs, value, and access from the purchaser perspective. And Sulan Milnarnik is a labor purchaser from SEIU 1199, and he will give the labor purchasing perspective. So each panel will offer some brief perspectives, and then hopefully we'll have some good discussion with everybody. So Dorothy, you want to take it away?
Sure. So Eileen, are we going to go through question by question, or are you like there's
that's a good, I think each one of you just speak
just
and
answer this
then
one?
we'll
Okay. All right, perfect. So speaking as a consumer here with my experiences with healthcare consolidation, I think I go back many years living as a resident of Washington State. And when I first remember thinking, oh, there's like 30, 50, however many hospitals there were in there, you knew how many there were in where I live in Seattle and which ones were good for which things. And you went out and hunted down your own primary care docs. And it's changed amazingly, so that now we just learned there are 8 systems in the state. And I think the experiences that from a consumer that I worry about are what happens to access, number one. Like all of a sudden, who you thought was your primary care doc is now part of a system that may not be covered with your insurance. So you have to go find someone else if you can find someone else. So I think the questions around healthcare consolidation from the perspective of consumers is really mostly my worries are from a financial payment affordability perspective. How do you find people to take care of you when the systems are all consolidated and so tightly wound up in their own little networks or big networks? And then from a health improvement, like who's looking out for me? Who's making sure that I'm getting all my immunizations, et cetera, if I'm not able to understand how this consolidated market works and who's got hold of all my data. So on the other hand, from a consumer perspective, there are some potentially, although I don't think we've seen the potential fulfilled, of having more reliable systems. You would assume that with bigger systems, there'd be better internal mechanisms for tracking people's, making sure they're getting their immunizations, et cetera. Making sure that with that economies of scale that's always used, that prices come down, affordability goes up. So I think even though that's what you hear when you hear about the consolidations, it's not the actual experience of consumers. And I actually personally, even though you all probably know I've been in healthcare at many levels in the state, I personally wish as a person, just a resident, that there was a larger voice for patients, or people, who's there to make sure that I'm being protected and supported in my healthcare access world and the quality of care I'm delivered. So who's there to support me, represent me, protect me, defend me, as you look at the bigger state level of what could potentially be done? I don't feel like there's a very clear line of sight that you can have confidence that the Washington state is really first and foremost looking out for what happens to all the people that live in the state when these consolidations occur. So that's kind of a few thoughts, Eileen, to get us started.
Okay, thank you. Katrina, do you want to go ahead?
Yeah, thank you, Dorothy. I appreciate your comments. Also, I appreciate the opportunity to provide our perspective. As the only healthcare entity on this panel, we are hopefully going to be able to offer some insight not only on the healthcare delivery perspective, but also as major employers and purchasers of healthcare as well. I think that might be something that isn't remembered, but some hospitals are the largest employers in their counties or in their cities in the state. So I'll be addressing our experience with consolidation more in one of the later questions, but I wanted to just start by taking a step back and touch on information that was presented to the board that Ross had covered briefly, and those strategy options that are being considered. They do largely target hospitals, I think, under the assumption that consolidation is reducing competition. There's the worry about increasing prices and threatening affordability or access. I think where our concern is, we actually really support the board doing analytic work to gather more specific concentration data in Washington, because I feel like that's where we're lacking that evidence. And that's just coming from a place of wanting to ensure that policies are targeted and that they're solving issues that exist here in Washington based on evidence. Another thing I want to point out is that what makes the Washington hospital market a little bit different is that all but 2 acute care hospitals in Washington are nonprofit and operate largely negative or on low margins. So for us, the question really is, what's being gained by a merger? And again, to the question of why is it occurring? I think we feel pretty strongly that the focus should be on sort of the upstream cost drivers that create pressure to consolidate. Because if we aren't looking at those drivers, then oversight, I think as the board is currently contemplating it, we don't think will do much to improve access or affordability. So thanks again for the opportunity.
Okay, Justin.
Thank you, and thank you for the opportunity to join the panel. I think as far as my experiences, both as a nurse practitioner, as a registered nurse at the bedside, and a healthcare consumer, I've had experience working within systems where there have been consolidations, primarily, 2 systems or 3 systems kind of coming together, and I think that for workers that are working within these systems, regardless of whether they're represented by either collective bargaining or not collective bargaining, I think there is a consensus if you really do ask these healthcare workers as far as the ability to change policy and adapt policy to specific regions or specific localities, have a say in the process of how care is delivered to meet the needs of the community. And the patients that they serve. I think when we look at access to care, especially under, if there's 2 nonprofits that may come together, one may be faith-based, another one non-faith-based. The faith-based exemption for contraceptive services, for example, if the parent organization is faith-based, they can claim a religious exemption for their employees to access certain services such as reproductive health care and contraception. And they also potentially have a direct impact on services that are provided by the merging organization, such as LGBTQIA plus care and reproductive care. So I think that from a provider perspective, many of the patients I see are still dealing with troubles related to certain consolidations, some of the ones that were mentioned earlier. One example, United Health Group, parent organization to Optum and United Health Plan, they have a Medicaid plan in the state. And I'm frequently seeing patients that are not able to access Optum clinics. Optum is under the parent organization of United Health Group because Optum will not see them with the United Healthcare Medicaid plan. So I'm seeing more confusion amongst patients when certain health systems come together, and there's also kind of more battles between insurance companies and health systems as far as contracting goes as well. So I think just in a general sense, there are concerns at the provider level, at the healthcare worker level, and the consumer level. Thank you.
Okay. Michelle, from the employer perspective?
Yeah,
Or
hi.
not employer purchasers, I'll get it said yet.
Yeah, employer purchaser, thank you. Thanks for the opportunity. I've been working on the employer health plan sponsor, employer purchaser of employee benefits for over 20 years. I worked for, and during that time I was with really 3 employers, both in the public and private sectors. And I would say that I'd like to focus a little bit more on the last 2 years. Our experience has been that with the growth of, and right now we'll talk about hospital systems, that there's a consolidation going on everywhere, but it's over the past 2 years, we have really seen a big increase in, we experience it 3 ways. Threats that, and this is through our health plan, threats that the hospital system is going to leave the network unless they get a big rate increase. 2, the health plans eventually given to demands because the hospital system is so big, it would leave a big hole in the network. And 3, an increase the cost for us. We don't know what those costs are because, of course, they don't tell us until the bills come in. Over the last 2 years, we've had at least 5 health systems threaten to do this. And 4 of those cases, it came to within 30 days of the contract ending. So letters were sent out to our employees that were enrolled. It was very distressing to them. We get a lot of calls and questions, which we can't answer. Just last year, last open enrollment, 2 health systems threatened to leave, either before or during open enrollment, which was, kind of put us in the middle there. And there's actually one going on right now. So it's definitely happening faster, and I would say more furiously. And then moreover, in terms of the cost side, I mean, costs have been going up above the cost of living for the, with a few exceptions, COVID and when ACA went into effect. But other than that, it's gone up above the cost of living every time. And over the past 2 years, our costs actually increased more than our actuaries projected it to go, which is very rare, but 2 years in a row it happened. And it was, on the order of 8-9%. And when we did an analysis of that, about half of it was due to price. So we've been saying for years it's unsustainable. It really is unsustainable. We actually had to start instituting employee premium. I know people would probably be shocked that we haven't already done that, but it's something we prided ourselves on. But we had to dig deep in our own budget, but employees also had to contribute. So that's been our experience the last couple of years.
Okay, thank you. And Sulan.
And apologies, Eileen. Sulan is feeling under the weather today and is not able to make it.
I wondered if he'd made it.
Apologies.
Okay. All right. Well, so then do we want to go? Do you feel like you all spoke to the other? You want to go to this question now? And I don't know whether you want to go through the same direction, Dorothy?
Sure. We can, and that it'll be very predictable what our turn is. It'll be great. So, I think this question, it's a chicken and egg. The health systems get bigger, and the health plans have differential pricing based on the size of the system, because they know they need to have good coverage in their network. So it's kind of I like to think of virtual cycles, and this is the opposite of that, where everybody gets bigger and then they can have more negotiating power with the health plans, and then the health plans, you get into those dynamics that Michelle was discussing. And I was thinking about this, that, if there's we lose sight of why we're doing this, which is for patient care and for supporting providers and providing really good quality care. And so if the focus is only on the financial aspects of mergers and acquisitions, without tying price or rate increases to proven improvements in quality and in access, then we're going to just keep, in my mind, we'll just keep seeing that spin up and up and up. So until you need the giant hammers to get control of the whole thing. So I think that for me, the idea of having consumer input into what's important when you do these consolidations it's access, it's better quality, it's increased convenience, it's greater support, innovation. I keep thinking we're so focused on this price thing. There's no room for the innovation and care delivery that we all would hope to have. So to me, that the one thing that could help all of this is to have, I think it'd have to be kind of at a state level, have a tie between, if you're going to do these consolidations, which, you know, you can arguably say that's important for good IT systems and stuff like that, then there has to be, along with those, the rates and the consolidation strategies, not just, oh, it's economies of scale, trust us, or, oh, we're going to improve quality, trust us, or we're going to be able to, you know, get more providers, a better workforce, trust us. Well, there has to be, I think, and this is not to cast dispersions on people's intention, but there has to be a tighter, stronger link between the requirements to prove improvements in quality with the consolidation. I just don't think that if you only focus on the money and like reviewing what's happening without any stronger consumer input, powerful consumer input into what that's going to mean for the actual people that have to pay increased premiums, pay more co-pays, increase confusion about where they can go, deal with, you know, whatever kind of secular, non-secular healthcare there is. We're not going to make progress. We'll just be admiring this problem. So if as a consumer, I really wish that there was a powerful counter force, or maybe it's a complementary force, to make sure, well, if we're going to do this consolidation for all these good reasons, then let's for sure show that we have those outputs and outcomes that we're saying we want.
Okay, thank you. Oh, Katrina.
There we go. I'm off mute. Yeah, thank you so much. But we agree, you know, the focus should be on access to services, you know, in consideration of an increasingly expensive environment to provide care. I think one of the things we want to underscore is that integration and strategic partnerships largely occur in Washington specifically due to financial and operational challenges. Couple of examples, Evergreen Health Monroe was down to very few days cash on hand when it partnered with Evergreen Health. Without that partnership, it likely would have closed. There were 2 hospitals in Yakima. That county has the highest concentration of Medicaid patients in the state. So it's honestly nearly impossible to operate without incurring losses. One of the hospitals closed and the remaining has changed hands several times. We want to make sure that, especially in rural areas, hospitals can stay open, given their payer mix, given the challenges that come with being in a more rural area. Wanting to touch also on some of the cost pressures. We have one of the highest labor costs in the country, and we also want to be able to attract the best workforce. Again, speaking to low Medicare and Medicaid reimbursements, they don't cover the cost of care, which makes it really difficult, especially if your payer mix is largely government. Administrative requirements for carriers, that's a big one. Costs associated with prior authorization, delayed payments, coding, billing. There's a lot of requirements that are needed to be met before carriers will pay any claims. There's also your medical technology, your equipment, having an electronic health record, the training, time burden, you know, purchasing that, maintaining those systems. There's state and federal cuts in taxes. We also have an aging and sicker population. So it's a lot of these considerations. With that, wanting to say that, you know, hospitals in Washington are dedicated to providing care and are essential to our communities, but we also want to make sure that care is available, and sometimes that does require strategic partnerships, either with other hospitals or clinics or systems, because they really do provide both the human and financial capital needed to help preserve access to care in a community. And it might sound hyperbolic to say merge or die, but that's sometimes what they're facing. It's, merge, or they don't have the resources to continue operating. So in doing that, also you get the opportunity to sort of draw these points, sharing financial risk, being able to streamline compliance and business functions, creating efficiencies, easing the burden. So I think it does create more of a resiliency. But I think our biggest perspective is that the approaches allow us to sustain services and access in communities. And considering, especially now, there's a lot of uncertainty, and there's also a lot of pressure on hospitals to reduce costs, but also, pay well and have, access, quality, cutting edge care. So those are a couple of the things that we wanted to point out. I'll just get briefly into the strategies. I know we have a couple more questions and more people, but the way we see it is, if market oversight is intended to be a tool for early warning and strategic intervention, the strategies and solutions we feel should be focused on addressing the drivers of consolidation, not just the impacts or what happens after the fact. I forget, Dorothy, how you said it at the very end, but it sort of summed it up perfectly. We're just going to watch it happen. So a couple of those things maybe for consideration of, if government pay the cost of care plus a reasonable margin like they do, or like how MCOs are paid, and regulatory mandates were either funded or they were at least, narrowly tailored, and not overly costly, that would be a huge help. Making sure that new regulatory burdens are adequately resourced, with respect to staffing or infrastructure and funding at the state level, that reporting requirements have clear benefits to patients and communities. So just being more mindful of the obligations that you're putting on hospitals and the costs that are incurred because of them. So thank you.
Okay, Justin, you want to?
Yeah, I think from my perspective, at least, there's different types of consolidations, and the reasons for why they occur, they can differ. But I'd want to echo what was mentioned earlier as far as looking past, obviously, looking at finances is a relevant piece of this, but what does it mean for the patient at the, the point of care? I think that, oftentimes I do see the point made that, consolidations may increase access, but I think that the actual implementation of it is a lot more complex than that. For example, with systems that I've been involved with and other systems where I've seen patients that have come from those, many of them have found that accessing the system, seeing their primary care provider, moving through situations like red tape of, call centers and kind of blanket scheduling procedures, that actually impacted their ability to access the system. And then also when we look at costs, if we're looking at, based on the data, increase in costs associated with consolidation, that cost has impact on patients' ability to either seek care or access care. And what are the downstream impacts of that as far as, say, emergency visits, higher acuity visits that could have been prevented. And also looking at it from the patient's perspective, when there are these consolidations, there are many changes that are made. The healthcare system is already very difficult to navigate. And when policies change, scheduling processes change, and access mechanisms change, that can impact patients' understanding of the healthcare system and their ability to navigate that system directly.
Great, thanks. And Michelle.
I struggled with with the answer to this question. I wish I knew the answer to this question, but I mean, yes, certainly. Well, I support the efforts. I support the bill. I'm talking from for myself right now, not necessarily King County's position, but do support the healthcare market standard bills that are in the House, because why, particularly with the addition of having more transparency, including private equity investments. why is private equity going and getting into healthcare? It's because it's where the money is. And there's so much opacity and confusion, and things are much more complicated than they need to be. And that's where people are making money. So anything that can improve transparency, I'm for. One area that employers, larger employers that have enough people in a certain location are pursuing direct contracting with providers to see how, whether and how that will work. Some are having good experience with that. But my worries with that it's good to see it, as a pilot, if you will, but it's not available. It's not accessible by your average employer, particularly when you think about those that are fully insured. They basically have to take what they can get. But that's something that employers are working on now, just kind of out of frustration with respect to the current system, and really not paying more and more and not getting better quality and not getting better access. So that's one area that employers that are larger and more sophisticated are moving into. I don't have much more to say about that.
Okay, thanks. All right, so moving to I'm going to throw a curve to you guys because I want to make sure we have time for the rest of the committee to have comments that they have. So on this next question, can you address what you think is important to preserve, and then how the last question is about how to keep the public included. So I'm just going to say, can you add that with this question? So Dorothy.
Okay, thank you. The aspects of the healthcare system that are important to preserve, I keep this concept of the tragedy of the commons keeps coming up to me. So you think of a region that was mentioned earlier, and if all of a sudden all of the systems that were connected up in that region get get disrupted, because all of a sudden somebody else comes in and owns that hospital or that health system. That to me is kind of scary. I'm thinking about, sometimes in Eastern Washington right now, I'm hearing about some of the cardiac services that used to be such a beautiful part of that state region are getting disrupted because of consolidations, and docs are leaving and whatever. So I think preserving that, or the trauma system, or the basic ACH structures across the state that can potentially be part of that community health piece. We don't want to lose that. I mean, I do think the healthcare system in Washington feels much more innovative than many of them, so we want to preserve that. But I think the policies to ensure that, and it ties to that question about the public. I'll just throw this out there, and I'll probably get thrown off this panel, but I actually, much as I believe in the goodwill and I understand all the dynamics of what happens, I think in this case, the consolidation thing that you may not be able to stop, there has to be a tie to some sort of a rate setting approach that the public can be part of, that we can say, if we're going to raise rates, can we do a population-based approach instead of this fee-for-service? Can we say that the money that we're all spending in our copays, and deductibles, premiums, that we have a say in how those dollars are going to be spent, and that there's a role for the state in taking a little more proactive and kind of bossy approach, I guess I'll say, to say we can't keep this going, and people are suffering from it. So preserving the innovation in our state, preserving the emphasis that I think is there for quality, and the belief in access and equity for everyone, along with things like preserving the systems that are, and the provider systems that are in place regionally that people have grown to love. And then some of the statewide ones are super important, and the public should have a much more active role in what happens to their health systems, whether it's through and support the state in potentially doing some rate setting of some kind to make sure that we don't keep going in this ever increasing spiral of more costs. It's more expensive. You know, we have to do more consolidation. People pay more. We don't get good. We got to stop it. So I'm getting more radical in my experienced life with healthcare in Washington State and going, I think we need a little bit more of an activated state role, like Maryland has. So there you have it.
Okay, thank you. Katrina.
Thank you. Yeah, I think to Dorothy's point, you know, maintaining regional providers is often supported by partnership because of the cost, especially if they're in rural areas. I mean, when you're considering specialty clinics, if they aren't supported by larger systems, or if they're from smaller hospital that's predominantly, you know, services Medicaid patients, it's hard for those to exist at all. So I think, you know, that's one thing to consider. I think preserving that access and allowing for more access. But I would also, just to sort of flip it a little bit, considering, you know, whether that partnership or that merge or affiliation didn't exist, what's the impact to access and, you know, specifically services like emergency care, primary specialty behavioral health? What's the impact of access if that doesn't happen? And or on the other hand, you know, what services could be sustained or what services could be introduced if an affiliation were to take place? And again, like sort of to the point of, this is largely happening because there are financial challenges, operational challenges. It's difficult to operate a smaller hospital, and so you know, focusing on why it's happening, largely financial. If they can't do it, do they cease to exist? So again, like looking at it from the perspective of, if it doesn't happen, what's the impact? But also appreciate the comments about, you know, quality and wanting to make sure that patients are getting the best, you know, care, you know, which also costs money. So thank you.
Justin?
Yeah, I think I actually would agree that doing an assessment of you know, each individual situation, I think the issue here is that we are seeing situations where consolidations may not necessarily be to save an institution, but or say a health group or a specific practice group. But when we look at things like private equity takeovers, where the financial offer to, say, the partners or owners of a specific group that provide a vital service to a community, may be something that they can't necessarily refuse. And how do those practices stay afloat when profit is primarily the motivation? I think that really kind of gets to the crux of this, is when you're looking at profit and loss versus care delivery for people, which may not necessarily be profitable. How do you balance those two factors without driving up the cost of care? So I think that the piece with looking at the corporate practice of medicine is very, very important, because that really gets to those situations where takeovers may happen before a profit motivation. But then also, you know, for those nonprofits that do combine, I really think it's important that we look at access to services that might be lost because of a, you know, faith-based institution, non-faith-based institution, particularly reproductive care and LGBTQIA plus care, especially in the state where we do value access to those services. And for the public, I think, you know, I think having the public tell their stories about the difficulties in navigating care. You know, I myself see patients that have an insurance plan that was dropped by a major health group, and delays in care have led to missed medications, and coming into, you know, see me as an urgent care provider, and trying to manage things in urgent care as a primary care provider. And I think that those types of stories of things getting missed, they need to be told to, you know, enhance the understanding of what's actually happening on the ground for patients and for providers that are caring for them.
Great. And Michelle?
You know, I'm glad Dorothy brought up rate setting, because Ross said we couldn't talk about things like rate setting. So anyway, I'm glad she brought it up.
Oops, I'm sorry. I forgot.
Because that's why I couldn't speak on about one of my that previous question. So what aspects of the healthcare system are important to preserve? I think, you know, we've already maybe touched on it, but primary care and mental health care, which is critical. And they're not paid what they're worth. And that's one reason why employers in Washington State, and I'm active, by the way, with the Washington Health Alliance, with other employer members there, and I'm also active in the Purchasers Business Group on Health. So I do have a kind of a finger on the pulse of what employers think, and we all think pretty similarly. But in Washington, employers are really pretty encouraged about what the Healthcare Authority has done in terms of establishing a standard for what's going to be paid, a benchmark of, I think it's 200% of Medicare. And we're watching that and, you know, hoping it's successful and see what happens. And there are employers who want to join in on that because in a way, it almost feels like things have to break because things are not going well and haven't been going well. And I hear the concern about small hospitals and rural hospitals. And I think that would, you know, if you're paying according to a benchmark, they're struggling to survive because anyway, it just seems like that would raise the level for them. And with all this consolidation going on, a lot of these rural hospitals are closing. So I don't understand how the consolidations are helping access it. That doesn't, you know, we saw in previous slides that doesn't seem to be the case. So it just seems like we're telling two very different stories. But anyway. But that's primary care and mental health care. We don't have enough of it. Our employees have to wait months for a regular checkup, sometimes even for specialty care when a problem has been found as well. But in mental health care, we know there's a shortage of that. So again, the Healthcare Authority has increased what the payments are for that. So I see that as part of the solution, and looking forward to seeing how that pans out. Oh, and in terms of the public, yeah, they need to continue to share their stories. Of course, most of them are working and they can't come to meetings like this. So I appreciate any opportunities, you know, with the media sharing it, studies, ways for them to share online that can be surfaced and shared. It's really tough out there for people trying to find healthcare.
Okay, thank you. We have some time left for the rest of anybody from the rest of the committee that would like to, can you raise your hand or wave at me to add your 2 cents? I'm not used to Teams, so it's harder for me to figure out how to do this one. Go ahead.
Yeah, so just a narrow question, really. So thank you for very, very useful discussion. Thank you for the panelist. I enjoyed that. And seeing the same problem from several different angles is a really good way to dissect it. My narrow question is that consolidation is often involves ownership changes. And what I wondered is whether people feel that the state as an entity has the power to dissect ownership structures in the way that it would seem to be necessary. Is this something that is likely to need legislative intervention in the future, or do we think that there's sufficient power for, I'll say, the state, particular entities within the state, to be able to have access to just a simple, narrow issue of ownership structure, who's owning, who's benefiting, who's controlling a variety of medical facilities. The reason I ask is that, I think it's, personally, I think it's opaque. I think it's very opaque. I think even if you try and dig into it as an intelligent, reasonably well-informed person, you hit a wall very quickly. And so from the perspective, Michelle, Michaela, of the consumer who is approaching something from a fairly naive, perhaps not well-informed initial position, it's almost impossible. And then legislators themselves often seem to say in conversations that they have difficulty penetrating a lot of the opacity. So I'm wondering, is there a legislative change that is likely to be needed? And if so, do the forces need to be marshaled to initiate that?
Well, I'll just answer what I know. I know the insurance commissioner's office has done work on this, trying to follow the lines to know who owns what. And I believe they think that they need more legislative direction. Ross, do you have anything to add on that? That's
No, I would agree. Currently, carriers, that's in the law to conduct the market oversight activities there. And like you said, Eileen, there is some interest in expanding that. Regarding what we've talked about here today about healthcare facilities and mergers and acquisitions, I'm not aware outside of facility-specific statutes or regulations that the state currently has authority to kind of conduct the ownership transparency activities that, we've been broadly about today. Each facility type in their licensing process often has to give over some ownership documents and charts and things like that. But I don't necessarily think that those would be able to be drawn over into a market oversight program. So I think that's a long way of saying there probably would need to be some legislative action taken if we did want to pursue ownership transparency related to healthcare facility market oversight, would be my 2 cents.
okay. Any other comments, questions? Katrina?
Just wanted to follow up on the public role. I had forgot to include that in my answer. So we had a couple of thoughts, just mostly around AGO and publicly posting pre-transaction notice information, having the opportunity for the public to submit comments, having public hearings around pre-transaction notices, so that there is a venue or a forum for the public to be able to provide their perspective. So we thought that might be a helpful or valuable opportunity for the public in terms of engagement. And just one note about the private equity piece. With respect to hospitals, there's very limited private equity involvement. So just wanted to make that clear. So thank you.
Okay. Anybody else? Okay. I don't see anything. I was going to throw in after all this discussion that just this week the KFF had a forum that was on this topic, and if you're interested, they recorded it and it's a podcast, so you can go in and get it as a podcast, which I thought it was pretty interesting. I know they had somebody from the Pacific Business Group on health, and I think Aaron Fusé Brown was participating, and there was someone else, I can't remember where they were from, but they were basically having the same discussion we were having today. And if you need a little more primer on it, I thought it was very good in that way too. So I guess that moves us. Ross, did you have anything that you want to add, or shall I wrap it up here?
I just want, first to say thank you to you, Eileen, for facilitating this for us. You did an excellent job as always. And thank you to the panelists. And just wanting to put it out there that, again, the goal of this is to hopefully bring back to the cost board your expertise and in these areas related to market oversight. So if there is anything additional that you weren't able to say today, or you'd like some more time to think about it, please feel free to email us. We don't have the opportunity to put it in chat, so we'll direct you to our website. But would love to hear from you on any additional thoughts on this topic. Relatedly, as we've started to separate stakeholder and had issues advisory committee meetings and really trying to focus on bringing your feedback to the cost board. Would love to hear any feedback on how this went, ways that we could improve, this process, or better ways to get your feedback to the cost board. Would love to hear that. So please let us know if you have any thoughts related to that. And I will hand it back to you, Eileen, to wrap us up.
Okay. Well, then that brings us to the end of today's meeting. I want to thank everybody, for our panelists, the presenters, and the committee members for sharing your perspectives and your time with us. It's essential for us to get everybody's input. And as you're supposed to be an advisory board, so we definitely want to hear from you. Your engagement and expertise are critical for the Azure advisory role in our goal to improve affordability and transparency for Washingtonians. A recording of today and summary of today's meetings will be posted on the website shortly. And our next meeting date has not yet been finalized, so we will let you know how that goes. Staff will follow up once it is confirmed. Thanks again. I look forward to working with you all in the future and at our next meeting. So have a good weekend.
Thank you all.
Thank you.
So, bye.